Hello and welcome to today's webinar of atrial fibrillation. I'll be talking about some introductory part, then we'll be discussing in details about anticoagulation aspect of atrial fibrillation. And ultimately there will be a panel discussion by all the speakers. So without wasting time, I'm starting this introductory lecture of atrial fibrillation. So atrial fibrillation has a fascinating history in that it was recognized more than 100 years ago by practicing physicians as a manifestation of irregular pulse. It was officially recognized as it is known today when electrocardiogram (ECG) recordings were introduced and ultimately analyzed. So currently the diagnosis and management of atrial fibrillation has gained great importance, as we all know that it is a known risk factors for development of stroke, heart failure and cardiovascular complications. In fact, it has been seen that atrial fibrillation can occur even among persons with no known cardiac disease and without other risk factors even for it, and ultimately it predisposes them to develop several complications in terms of morbidities and of course increases the mortality. So first of all, atrial fibrillation. What is atrial fibrillation? There are definitions for atrial fibrillation. So what is atrial fibrillations? Atrial fibrillations can be defined as supraventricular tachyarrhythmia characterized by uncoordinated atrial activation with consequent deterioration of mechanical function. So it's a complicated definitions, but it's a pretty simple also at the same time, because it's a supraventricular tachyarrhythmia. It's a chaotic atrial activity. There are different types of atrial fibrillations. This is called first diagnosed atrial fibrillation. Some classification characterized as a paroxysmal atrial fibrillation that terminates spontaneously or with intervention within 7 days of onset, and episodes may recur with variable frequencies, and usually it is self-terminating in most cases within 48 hours, but some may continue for up to 7 days. And any atrial fibrillation episodes that are cardioverted within 7 days should be considered as a paroxysmal also. There are little debates regarding this, but still we do consider it as a paroxysmal atrial fibrillation. Another variety is a persistent atrial fibrillation, so continuous atrial fib that is sustained more than 7 days. So if that lasts longer than 7 days, including episodes terminated by cardioversion that I initially told, either with drugs or by direct cardioversion, after 7 days or more, we call it a persistent atrial fibrillation. Then long-standing persistent atrial fibrillation, it's a continuous atrial fibrillation more than 1 year in duration. So continuous if lasting more than 1 year, irrespective of intervention, it's a long-standing persistent atrial fibrillation. And lastly, permanent atrial fibrillation. So that a permanent means and this term permanent used when the patient and clinician make a joint decision to stop further attempts to restore and maintain sinus rhythm. That means it is kind of permanent whatever you do. An acceptance of atrial fibrillation represents a therapeutic attitude on the part of the patient and clinician rather than an inherent pathophysiological attribute to atrial fibrillation. So a fib that is accepted by the patient and the physician, hence rhythm control intervention are not pursued by definition, we called a permanent atrial fibrillation. There may be another varieties or categories by which it can be differentiated, like valvular AF with atrial fibrillation who have certain underlying cardiac valvular disease, be it rheumatic, degenerative or any other types, and non-valvular atrial fibrillation, that in absence of rheumatic mitral stenosis or any mechanical or biprosthetic heart valve or mitral valve repair. So this can be categorized by different types. So now we'll be talking about risk factors for atrial fibrillation, and what are the risk factors for development of atrial fibrillations. Multiple risk factors contribute to the development of atrial fibrillation. First of all, age. Dramatically, it has been seen that with increased age, the risk of atrial fibrillation increases, and it's an independent risk factors, and with its own complications has been seen in aged individuals, especially more than 65 years of age. Second is body weight. It has been seen that overweight and obesity are one of the risk factors for development of atrial fibrillation, and it has been reported that it has a strong association with atrial fibrillation, uh, with the risk increasing in persons who have obstructive sleep apnea. And although the underlying mechanisms between atrial fibrillation and obesity is not clearly understood, it has been suggested that structural changes in the atria due to deposition of certain substances, fat, can lead to stretching and consequent rise in atrial pressure, interstitial atrial fibrosis, ultimately producing arrhythmia. Some have also postulated that fat-induced inflammation could lead to certain factors that ultimately generates atrial fibrillation. Third important factor is hypertension, systemic hypertension, and it increases the risk of development of atrial fibrillation. At the same time, increases the risk of development of complications in patients already having atrial fibrillations. Fourth is diabetes. Diabetes has long been known as an independent risk factor for developing atrial fibrillation in both men and women, and the almost twofold increase in several studies has been seen for development of atrial fibrillation. Furthermore, several recent reports found that the risk was most pronounced in young diabetic patients. That's a very worrisome thing. And almost 1 in 5 patients with atrial fibrillation, it has been seen to be suffer from diabetes, which itself is a major contribution for thromboembolism and death. And longer duration of diabetes has been seen to be associated with more predisposition to development of atrial fibrillation. And lastly, not the least, is alcohol consumption. It has been seen that binge alcohol drinking in the presence of cardiovascular disease substantially increases the risk for development of atrial fibrillation, especially in persons aged more than 55 years. So these are the risk factors for development of atrial fibrillation. Now coming to pathophysiology of atrial fibrillation, there are multiple pathophysiological mechanisms for development of atrial fibrillation as a consequences of the presence of multiplicity of the risk factors that play a role in development of atrial fibrillation. I'm not going into details of this pathophysiological mechanism of atrial fibrillation, but it has been seen in electrophysiologic studies that initially the AF cycle is shortened because of changes in the calcium and potassium ion environment. Once structural remodeling sets in the atria, and the AF cycle is prolonged, and this can play an important role in guiding therapy. That's a different aspects of pathophysiologic mechanisms which implies certain interventional aspect. And some study also pointed out that focal activity involved in atrial fibrillation is in the pulmonary veins, so isolation of that area may also help. So these are the few important aspects of pathophysiology of atrial fibrillation, but there are lots of it, and I'm not going into details due to time shortage. And then after this short pathophysiology, I would like to say that screening of atrial fibrillation is very important, and as because the risk of development of stroke is very high, and therefore it is very essential to screen for particular aspects of patients. And why it is so? Because despite the variability in published epidemiological studies and the prevalence and incidence of atrial fibrillation, it is clear that magnitude of atrial fibrillation as a public health problem worldwide and its consequences are colossal, especially in view of aging population in all the countries, and due to increased prevalence of other increased risk factors associated with cardiovascular disease. It is very important to control it. And morbidity and mortality associated with atrial fibrillations, sudden death, 10 to 40% of the atrial fibrillations lead to hospitalizations, heart failure or stroke leading to death or impaired quality of life, and then almost 30% of stroke, it has been seen, due to atrial fibrillation. 20 to 30% of atrial fibrillation patients have valvular dysfunction, and vascular dementia, cognitive decline may develop even in patients suffering from atrial fibrillation, even those who are properly anticoagulated. So a large number of patients are suffering from atrial fibrillation, and it is projected that a large number of patients, millions of patients by 2050 all over the world will suffer from atrial fibrillation with its inherent complications. And the global burden of disease, if we talk about, then atrial fibrillation imposes a great burden, be it physiologically, be it socially, and be it economically. And epidemiology is really alarming, as the aging population has also increased in the society. And if we talk about specifically of India, then epidemiology of AF in India compared to Western data, not much data is available regarding the incidence and prevalence of AFib in India, possibly because studies have been sporadic and mainly conducted in focused geographical area, not as a whole. However, still based on data, I would like to comment that the mean age was pretty low, 45.4 years, and with 51% age less than 50 years, and only 16.3% more than 60 years in a study carried out in Andhra Pradesh. And the mean age was 47 years in a study from Bihar, and majority of patients were aged between 51 to 60, that is almost 48% of the patients. In a study carried in northern part of India, the mean age was 51.2 years. Among the AFib patients presenting to a tertiary hospital in Gujarat, almost 46% were in the 31 to 40 years of age group, 31% were between 41 to 50 years, and 15% were being 15 to 30 years. These findings were further confirmed by IHRS AF National AF Registry of the Indian Heart Rhythm Society registry, comprising of 1532 patients with AF from 25 participating centers, with a mean age of 54.2 years, the range from 15 to 96 years. And the Indian subset of Realize AF and the Rely AF studies with AF was 60 years. The IHRS AF data revealed that 36% of patients were aged more than 60 years, while almost 18% of the patients were aged less than 40 years. Therefore, what I mean to say is that the increased prevalence of AFib, atrial fibrillation, in younger population in India may be consequent to the fact that the rheumatic valvular activities, rheumatic heart disease is an important cause, and maybe the underlying etiology in 30 to 40% of the cases. And this rheumatic heart disease is more frequent in the younger population. Hence, a greater proportion of Indian patients have a persistent, even a permanent atrial fibrillation, which represents a high risk for development of stroke. And as a gender, if we do talk about, then the Western data showed that a higher male preponderance, male is to female 1.1 to 0.8. Studies from India have shown women to have a slightly higher preponderance of AF than male, And then talking about the types of AF, we have already talked about the types of AF from in that in the Indian subcontinent we do found more kind of persistent and permanent AF. The causative factors are the same like the Western data, and so basically the differences is not pretty much understandable in terms of pathophysiology, but yes, there are certain changes in Indian data compared to Western data, is because the more number of younger population is suffering from a FIP. That's a prime concern. So with this, I would like to invite my next speaker regarding the further management of atrial fibrillation and how we can proceed. So thank you.